So let's get to the next slide. Okay, so I'll be very frank and tell you that this is me as a patient. So a 36-year-old G2P1001 at 32 and 2/7 weeks presents for her routine OB visit with worsening symptoms of anxiety. She reports waking up at night at approximately 3 a.m. and unable to fall back asleep. She has an overwhelming sense of doom and constant worry about her family. She reports feeling like the bottom is about to drop out. And I remember telling Dr. Burgess at the time, I just felt like everything was so perfect. Like I had a wonderful toddler, a loving, supportive husband, and I just felt like what's going to go, what's going to drop, what's going to happen. And I was perseverating on traumatic events involving my husband and daughter, and I really had no previous history of this. I had an uncomplicated pregnancy and a prior delivery. I wasn't on any medications, just prenatal vitamins. And so I think this is very common in our patients, and I wanted to just kind of go over that a little bit because we see it time and time again. Um, so after discussion with her physician, she declined meds and therapies, but did make some lifestyle adjustments. I actually recognized I had been watching Breaking Bad with my husband night after night as we went through that episode where he became just normal teacher to a huge drug dealer, gang lord, and and so maybe that was some of my anxiety provoking activity, but we did kind of limit doing that anymore. I discussed how I was feeling with my family, and I really prioritized daily physical activity, and it seemed to get better with time. And I really never had those feelings again, even in the postpartum stage. But it was very noticeable of a change for me in that second pregnancy. And so I just wanted to talk a little bit about peripartum anxiety. I know Dr. Gill talks about this and sees this all the time, but it is a really big part of our WECO clinic here, like the clinic that I'm doing today. And I find that I see it a lot in the postpartum time, more at like 6 months postpartum, as their life gets back to normal and the anxiety really can rev up. Some aspect can be normal. There's lots of changes to family and life. They're anticipating their delivery, but it can significantly peak after delivery. So we want to really screen to see if this is an anxiety disorder, if there's some PTSD, if there's some panic disorder, and to treat that appropriately. So some of the tips and tricks that I do for this is discuss if it is interrupting their daily activities and how much it's really bothering them. I recognize that it can be very prevalent in the postpartum, and so almost all of my patients, I have them come back to see me for an annual exam at 3 to 6 months postpartum. So I see them for that 6 weeks postpartum visit, and then I schedule a follow-up in 3 to 6 months. So I guess that's like 4 to 8 months, just to make sure that something hasn't revved up that they need to see me about. And I'm not afraid of treatment or referral to treatment. So I ask what's worked for them before, and if they've had this before, or if they don't have a history, then I usually will start either sertraline or Lexapro or Celexa, one of those. I will use benzodiazepine sparingly, especially in my postpartum patients, especially if we're having a lot of perseveration around thoughts. But I try to get, that's often while I'm waiting for a psychiatrist to get in the picture. And I encourage you to really know your therapist in the area. I try to know ones that will accept Medicaid insurance versus Blue Cross Blue Shield versus our Aetna, I guess now it's Promise insurance from Prisma, just so I have an idea of the most common areas that I can refer to, and then just optimize optimizing that treatment, whether it be for therapy versus for medicational treatment or just time and listening from their provider. And then I know we all know this, but we use Mom's Impact very regularly in our practice. Our nurses have the flyers and they talk to actually every one of our patients if they want a referral when they do their OB intake. And they also talk to them about other resources in the area as well as part of their OB intake so we can try to help patients who need this. So some red flags is anxiety can often coincide with depression. And so when there are symptoms of depression, that needs to be screened for and treated as well. Often suicide ideation is more common when you have anxiety versus depression alone. So when you have that mixture of the anxiety and depression, that's when you're more likely to have some suicidal thoughts. And we definitely want to screen for bipolar, any episodes of mania, or for postpartum psychosis. And I talk to them about how intrusive thoughts can be very normal in the postpartum period, but it's when they really are triggering us to act differently or causing other problems in our life that we really need to think about them and look for treatment. So I just wanted to go over those few things and not forget a very important common problem that we see in pregnancy.